Warm welcome to our board directors in public. I'm Sean Duggan, the chair, and we have quite a lot of business to get through. So, just a few administrations. Welcome. I want to welcome Lynn Hunt, our new non-executive directors, Lynn Hunt and Cheryl Lee, for sitting here with us. It's really great to see you. It sort of feels like a long time in the planning, but you're here. Anil and Abiola and Anna are joining us online. Good morning, Anil, Abiola and Anna. And hi Anna. I know you had a bit of an injury very recently, so really kind of you to join us, but we understand that you'll be in quite a bit of pain. So let's see how we go. Nice to see you. Yes, joining us is we know that we've had a campaign to increase our numbers of governors, particularly staff governors, and one of our new governors, Jess, is joining us as a member of the public, and it's lovely to see you. Thank you very much for spending the time and coming to join us today. Teresa Barker, CNO, Health Centre Apologies, and we'd like to welcome David Wilmot, who's working with us on an interim basis at the moment. Dave, great to have you. Are there any additional declarations of interest to let me know of? That's fine. The meeting is quiet. Can I seek approval of the minutes of the board of directors held on the 5th of June? Right. And there aren't any questions from members of the public that we've received. Takes us on to the chair's report, and just as a quick update, you'll recall at a board development workshop that we had, I think last time, we had a focus around race equality, and we also had a focus around governance, corporate governance, and how the board should be running with our quality committees and our other committees, etc. It was really useful, and one of the things I took away is that I often find that we've got a lot of business to get through, and we just have to be very careful about managing the time so people get their contributions in and their questions and challenges. Really important. And one of the lessons we learned is that we need to be more disciplined and think of the papers. Do they need that time and focus around giving time for items that really are going to warrant a discussion and sort of unpacking from the executives and then a discussion from the unified board. So in that, so bear with me because I'm going to be looking at that as we go through. So you'll see, some of the items are for approval, some are for assurance, and I'll share that and bear that in mind as I go forward. And also with that in mind, my report is self-evident. It's quite comprehensive this month because I think it sort of gives an example of how busy we really are at the moment and how so much is going on with changes from government and central senior leadership within the NHS, and of course that has knock-on effects to us and changes with the ICBs, etc. It affects us as well. So with that in mind, what I'm going to do is pass over to Jane for her report, and any questions or any comments around mine we can take at the end of Jane's. You'll see that I talk about the mental health implications, the factors around mental health for the 10-year plan. And there's an appendix in there that sort of goes through that in a bit more detail, which I think is quite useful. And that really does set the scene nicely for what Jane would like to say in her report. Over to Jane.
Thank you. Welcome to the new Neds, first of all, and to David. At the last board, I signalled that I was going to be changing the chief executive reports to a slightly different feel about it. A bit more of a view from the bridge and a bit more of a strategic feel to it. And this is the first one that is in the new style. So as before, I welcome people now and outside of the meeting on the style and format and what you want to see in the future. What I thought I'd do in this report, because we do have some new Neds and we have people at various stages in the journey, with us, I would do an overview of where we've come and what we've achieved and where some of the risks are and what we plan to do in the future in line with our strategy. I think first off, I want to say that having written it, I was really struck by the complexity of what we've been driving forward and the sheer scale of what we've been trying to drive forward. And it is not lost on me the impact that will have had on our workforce. So I wanted to say that at the beginning, because I think it's really important that although we've seen some positive movements, it will have had an impact on the culture in the organisation, and it will have has had significant impact on individuals. And I think it's important that we don't ignore that. When I first came into post, we commissioned Deloitte to do a report, and their report basically said we need to change, we need to review and look at our corporate services, our operational services, and our clinical services. So basically we needed to look at everything. And so we've been on a journey of thinking about how we do that in a way that is systematic within the context of really significant changes nationally and politically. So we're navigating this in a very complex and changing world at the moment. I think I won't go into all the detail of what I've written, because I'll be here forever talking through each of the lines, and some of it, they are just the examples that I've pulled out of what we've done. But I think I would summarise it as we've made changes to our divisional structures. We've made so that we are looking at sort of that collective leadership and devolved responsibility more. We've increased our reliance and our confidence in our data, so that we're more data driven. But we've also had significant changes, but both at board level and at SLT level. So we've had a development plan around board development, exec development, and SLT development through this process, because we have been a changing group. And I think we have seen improvements. We've seen improvements that start off with the launch of our strategy, which has we've spent 18 months developing that and co-producing it in a way that we want to signal we want to do business from here on out, really co-produce, bringing people with us. We've seen improvements in performance. We've still got places to go with it, particularly around our 12-hour breaches, our length of stay in inpatient services. We've seen significant improvements in our people, so things like our recruitment and retention, our sickness levels. We've seen, and our agency spend. We've seen significant improvements in our finances. I think we've also had significant improvements in our system relationships and our system working. I think the areas that we've still got quite a lot of work to do is around quality. So we've put in place structures and processes in quality, but we haven't yet seen the outcomes change and the outcomes improve for our patients. So the processes that underpin it have improved. So we no longer have significant numbers of overdue serious incident reports. We no longer have overdue complaints. The tone of complaints has changed. So I can signal that we have done things with the processes, but if hand on heart, have I seen the outcomes translated to the outcomes from our patients as they experience our services? I don't think we have consistently. So quality has got to be one of our priorities going forward. And the other is culture. And I've signalled at the beginning when I spoke the impact of all these changes on our staff. And I don't think we can underestimate that. And we've got a job of work to think about how we manage that culture and how we actually improve our culture. So those two areas are the areas that I think really need the focus as we're going forward. And we have plans in place, and you'll all know that the board has signed up to put continuous quality improvement, and it's got quality in the title. So clearly it's about quality, but that is a cultural change. Ultimately, continuous quality improvement isn't just a process. It is a new way of thinking and a new way of working, and it is about ownership and collective responsibility and innovation and measuring and really driving and continuously learning. So though I think the CQI journey for us and really launching that and really embedding it in the organisation is going to be key to seeing the next stage of improvement for the trust. So I thought I'd stop there to give a chance to discuss and talk rather than just talk at you for a while. But thank you.
Just wonder, should we bring Funmi in just to elaborate a bit on the culture and the staff engagement and staff survey results that we've had and how we're going to address that?
Yeah, I was going to cover it in the ITPR, but I can cover that now as well. And so what we've done is a deep dive into our just speaking specifically about the staff survey, we've done a deep dive into our the analysis around how it's landed with our staff members. We have engaged on a significant number of engagement events and activities. But what we now have is year one, the 2-year plan that we put in place last year. And we've spoken with our regional NHSC and our regional colleagues to just talk them through that plan and to get their support for the plan as it stands. And we are now being supported with some ongoing check and challenge processes to continue to offer that assurance that we are on the right track. Similar to what Jane said earlier, we're putting the measures in place, but we recognise that it's a journey and it will take some time for our staff to begin to see that coming through.
And just to add, from my perspective, the reflection I have is when you think about the scale, the pace and the sheer range of organisational change we've undertaken in the last 3 years, it's certainly unprecedented in terms of my time within the organisation. And as Jane was saying, we shouldn't underestimate the emotional impact that has on staff, that degree and relentlessness of change. My other observation is that much of that change by necessity has been centrally defined and centrally driven. And what we need to be thinking about now is how we give staff and teams the improvement tools, the agency and the permission to drive change locally.
And we're going to hear more about this as we go through the papers. I'm going to come to Simon just for a contribution from Ned's point of view, but Anna first. Anna, yeah, your hand's up.
Yeah, sorry. So thank you all. And Jane, thanks for your report. And obviously, you know, I think this report's really evolved, and I appreciate the thought and the time that you've put into this, because I think it's really, really helpful. I think that just a couple of observations on that, and they do link a little bit to, Sean, something in your chair's report. I'm just going to start with that, because I think the DASH review specifically mentions strengthening patient and staff voice at board level. And I think that what I'd love to see more of in this report is reference to staff well-being as a priority for us, as well as and alongside the importance of strengthening the patient voice at board level and how we give thought to that. So I think Dan's points are really well made. I think there has been an enormous amount of change, but I think we have to be careful not to rewrite history here, because there's been a lot of quality improvement work that hasn't necessarily landed and borne fruit, in part because people have been trying to manage the changes that have been going on around them. So I think I suppose what I'm really wanting to sort of plant with you is in a probably not a very coherent way, but is the message that we need to be much more foregrounding what we're going to do about staff and staff well-being. And I think if you look at page 13 of your report and the data that we're getting from the staff survey, it's a very clear message that we're not doing enough.
Well said, and so we'll come back to that a little later, but the staff well-being is very well made. We'll have a few contributions. Simon?
Yeah, so again, I really thank you for the report, Jane. It's great it sort of provokes thinking rather than just tells us what we need to do. So thanks. I guess to pick up on Anna's point, one of the things which I'm really interested when we read the data is what people think of as the organisation. When you've got an organisation that's this big, often people think my service is great, but the organisation and feel disconnected to it. So I think there's a really interesting question for us, which is, what are people thinking about? And often that whole conversation about the corporates, the body corporate, rather than their service, and how we get that next level down of information, because that also is about then understanding what we need to do to help the managers and the people in the service to make that experience. Because I guess one of my areas, I obviously have to do more of is visits into services, but I'm always struck by either you've got the manager who's really supporting and cheerleading the whole organisation, or the manager who's saying, I protect my staff from the organisation. We need everyone cheerleading and supporting it if we're really going to change this. And I guess the only other bit I would just say, and so obviously when we're thinking about well-being, we often think about well-being and performance as separate, but it's so important that they're considered as integral to each other, and that sort of equity, well-being and performance driving each other and fueling each other, so that it feels absolutely fundamental to business, not a nice to have. To pick up on Anne's point about well-being,
Some of that granular, detailed analysis of the staff survey to give us a steer as to what we need to be prioritising and to where. That is part of the plan, which will So so I want to go to Abiola and John.
Hello. Moving slightly away from the staff survey for a bit, I just wanted to talk about the patient survey results. That's what's really heartening to see what the progress that we've made regarding the patient survey results. And what I really like is that I think we're trying to embody the accountability and the compassion part of our strategy and our values in the way in that movement, in where we look at the experience of how our patients are supported in making a complaint and talking about something that has happened to them. Because I think it's one thing to investigate something that has happened, but it's another is like, how did we do that? Did we show compassion as we did that? I like the fact that we're looking to do more one-to-one conversation, actually have a conversation with someone, actually picking up the phone or going to see them, actually saying, what's your problem? And just giving people that space to talk about what's happened. So, I really like that part of the report. That was really good for me to see that we were doing that and not just focusing on, just how many did we get done in a given time? Because sometimes we can reach those targets, but how did we reach those targets? And actually, did we improve our patients' lives? So I'm pleased that we have the balance right. I'm reassured about the direction that we're taking.
Thank you, Abiola. What I suggest we take Lynn, Dinesh and Kathy and John's comment, and then we'll hand over to you, Jane, just to some final comments on the report. Lynn.
So I really like the strategy and the fact that we have the opportunity to create again preparation for this board. And one of the things that struck me, Oliver, is around the issue of clinical involvement in the early stages of the strategy. Because I think what we see in the paper is we're going to do the next steps with our clinical teams and getting them involved. But I wasn't sure how much clinical involvement, and it could be in other places, and you know it very well. So apologies for being the newbie. How much clinical involvement there's been in setting out the whole strategy, rather than just having people involved in the clinical bit that comes next. And is there a strong sense, and I'm not just talking about doctors, but clinically across our services, is there a strong sense that this is something that is that kind of moonshot, or the thing that we're going to all get together on, and we're all ish on the same page? It's not never going to be perfect, but is there a sense of excitement?
Yeah, hold just a minute and then we'll so Dinesh and Kathy.
It's going back to what Anna was saying, and thank you both for your reports, incredibly clear and helpful. I was going to bring it up under any other business, but I think now is the time to just kind of raise the flag. Going back to what Anna was saying, I think we need a standing item on the agenda where NEDs feed back the visits, site visits, and what's gone on and what are the concerns being raised formally and informally under those. So if we have that as a standing item, even if no visits have taken place, we would not forget that this is something we need to look out for.
Work on that. We do that with a system in place, so we get the loop closed. Kathy?
Yeah, I just wanted to pull a few of these threads together. I absolutely agree with what Simon said, having done a visit last week. We met a very impassioned head of service who's done some fantastic transformation of the clinical model, but kind of as a bit of a lone ranger really, and feeling a bit disconnected from the body corporate, and not necessarily having had the support. If we hadn't had that individual and her colleague, that change might not have happened. And linked to that, I think I noticed that we've said that the strategy was a high level strategy, but I would really like us to talk more about it. I think that's what it's at the start. And that's what would get that local ownership and leadership. And I think the trick we're not sort of pulling off necessarily is describing how that clinical transformation improves outcomes, but also makes best use of our resources and helps us to live within our funding. So it's how do we sort of show that we're doing both through the transformation of the clinical models. So we had a lot about open dialogue, which was really interesting for me. So we also know and everywhere we look, we know we're doing transformation to our clinical system, but we're not necessarily articulating that as a clinical transformation. Hopefully CY help with that, but it's how we pull these threads together.
Yeah, no, really good. John, finally.
Thanks. I think it's just sort of to reiterate some of the comments that were made around the extent of organisational change that we've made, but I think it's important to stress that that's not static. So Dan mentioned in terms of the centralised change, but so we did a number of cases for change. We obviously did the corporate services review, but if a number of us could just list off now the same level of change that we're doing now. So I think we need to make sure that we're not considering it as a static process. We're just looking back. It's actually, this is very real now and will continue to be so. And I think there's just a slight nuance to that.
In my view is that I've been quite impressed with the clinical. You and I will both have that in mind, won't we, when we go through our work, Lynn? And I've been quite impressed with the clinical involvement. But that's not to say that, you know, as we embark on the strategy and do some of the deliverables, we've got to check they're still with us. On the medical side, Oliver set up a whole system of medical scientists get together. I've been to a couple of those. It's quite impressive. But Jane.
So thank you for all the feedback. I've written it all down and obviously it'll be in the minutes, so I'll be taking that forward and considering it all rather than going through every point now, if that's all right. But I think some really key things struck me as we're going through, and I think Abiola, the patient experience survey, I think I was really heartened by it because that's ultimately who we're here for. And I think we need to remember the patients and why we're here. And improving quality for them is really important, but we do that through our staff. And we need to look after both. It's not one or the other. So when I'm talking about patient quality and experience, it doesn't mean I'm not thinking about staff, because that's one of the ways that we deliver patient quality, but we are here to serve our patients. I think that I suppose one of the things that's really struck me is what Simon said about performance and being linked, that it's not being separate. I think that's really important points. I often talk about finance is linked to quality and quality is linked to finance, but that similarly performance is, and it's just stuck in my head that we need to think a bit more in that way as well. That's really helpful. I suppose to sum up, I suppose we're on a journey. This is, we said at the beginning 3 years ago of my tenureship as not beginning of the trust, clearly of my beginning as chief exec, that the Deloitte's report was a sort of a mark in the sand of where we were then. And then we've been on this journey for 3 years, and we've got the 5-year strategy ahead of us that gives us really clear markers. But it is fundamentally clinical. Can't do it without our clinical staff and without our clinical models in place. So I agree, Kathy, it's going to be fundamental. And Oliver is leading that from the helm, and is very vocal about clinical leadership and clinical models, which is really helpful because it puts a different challenge into the room. But we also need to make sure our service is safe, effective, and a good experience for our patients. So we'll be driving that forward, and I look forward to working with Lynn as the chair of the Quality Committee in driving this forward and being held to account here for the progress we're making.
And let's go to one of our clinical leaders. So
It's a lovely question. It's excitement. A little bit like Simon's response. I think some teams are excited about engaged. When I first came here, what I noted was there was an absence of local clinical leaders, in particular the clinical lead role. We redesigned those and created lead psychiatrist roles instead. I think we had about 6 out of 60 filled at the time when I came here. We've now got 56. Those sorts of positions are vital for that local leadership. And we're training them up in order to be able to provide that local leadership. I work clinically in a CMHT on Midlambton at the moment. And when the strategy was developed, the team came out to talk to NLP about it. I wasn't actually there on the day, but there was a buzz in the room when I came the next week, and people said they really enjoyed it and were excited about it. And I think that's what then allowed for what happened at the launch event a year later or so, when I think, Sean, you described it as there being a real vibe in the room. There were people from all professions and grades attending that meeting. I noticed some from my own team there. It was packed, and but in order to create that excitement in a consistent way, we've got to live it. And I think what, for me as a clinician, why it is such a good strategy is the values are extremely simple. There are only 3, and they are very understandable easily. And also our strategic objectives are very, very simple. There are very few of them. So for everyone that I work with is kind of concerned about waste. And it's a very easy thing to get on. So I think the excitement is up to us now to build it and to make sure it's consistent across our organisation.
Thank you very much. Thank you, David. Yeah.
Thank you, Sean. And I think the work that Colin will talk about later in terms of continuous improvement, I think will really be important in this conversation. I think when you look at some of the staff survey, I think that continuous learning culture will be really important. I think PSERV gives us a real bed to put that in. But it's moving that conversation in and embedding it and embedding the quality improvements and making sure the links between learning and quality improvement are really embedded. So I think that will help deliver that enhanced quality, I think.
Thank you very much. So let's move on to final report, board assurance framework. And this is again dynamic. Moving the BAF, board assurance framework, which will go through committees ahead of the October board here. So Colin, just give us the assurance.
Thank you, Chair. So the report hopefully does 2 things. So first of all is it presents our current BAF, which is a static position from the last board, with all of the various different kind of sort of BAF risks having gone through the committees that they're kind of responsible to at the moment. And obviously the SROs for those can talk to any particular kind of question specifically. The second thing that the paper just aims to outline is just where we are, if you like, in terms of the realignment of our BAF in accordance with our new sort of strategy following the RSM workshop that we had a number of kind of sort of months ago. There is an acknowledgement that we had hoped that by this board we would have managed to have developed the new BAF, have run it through all of the committees. But because of a number of factors, including constraints within my team, which has been picked up in Sean's report with the appointment of the new Director of Corporate Governance, that's been deferred through to the next board itself. What we have outlined here, though, is where we're at in terms of sort of the development of those so far, following on from the discussions that we have had, with some clarity around the proposed kind of committee oversight, the SRO, and then the alignment to the strategic ambition. The intention, this was discussed at an exec committee a couple of weeks ago. The intention being, therefore, that between now and our next board, that the SRO with the relevant kind of committee chair would then seek to define the risk description into something that feels meaningful, easily translatable and understandable, that we will then test through the committees a revised risk. And we have a new risk manager appointed who starts with us in 2 weeks' time, I think, something like that, which will be really helpful in terms of actually having some dedicated resource to be able to support and accelerate the development of these. And then the intention being that we'll then be able to present to the board the opportunity to kind of sort of stress test at the next board the sort of the new BAF risks. I think one of the things that we've talked about, we probably need to pick up outside of here, is some of the feedback that we had from RSM around the strength of stress testing that's happening in the committees themselves. So really making sure that within all of the kind of committees, when we're discussing our BAF, that we've got kind of confidence that we've got the assurance against some of the kind of controls that are in place, as well as that sort of general sense of kind of this kind of sort of reassurance. There may be some amendments that we need to make outside of here in terms of some of the specifics within this, but hopefully it presents an update in terms of where we're at, both current and proposed for future.
Okay,
Thanks,
great.
Chair.
So the next stage then will be the SROs, that's an executive SRO,
Yeah.
with the non-executive chairs and going through committees, yeah, great. Nitin, Chair, one of the chairs of the committees.
Yeah, so first of all, I really enjoyed the development session we had with RSM on board assurance, and it definitely cleared up for me a lot of how we look at BAF as a whole. And at the back of it, I'm looking at these sort of headlines and they all look like the right things. What I would love to do, maybe you've already thought about this, is when we come to discuss this in the committees to see what are the KPIs attached to each of them that provide us that assurance? Are there some things from the integrated performance report that we need to be picking out and saying, let's tag these three to this, let's tag these to this. Otherwise, how do I know whether that orange is orange or yellow is the right color to be in there? So yeah, that'll be a great step to sort of.
I think we need to move the conversation from just a list of kind of controls to then actually having the conversation around, okay, you know, what is the evidence that supports that particular kind of control? So what's the report, the document, the KPI that I can lay my hands on that says that control is having the effect that we're talking about against the kind of the risk itself? And I think that would be a really good move forward in our maturity in terms of how we as a board and the subcommittees use the BAF to drive our business.
Absolutely, and,
So, yeah.
and this could be a great discussion for the individual committees to have. Because I'm looking at governance and I have no idea how I'm going to say what KPI, but I need to think about this, and maybe we think about it in the committees.
Great. Great comment, thank you. Simon.
As you know, I've always struggled with BAF. So I frame it in this context. And it suddenly, when I was reading this, I was like, if I was an exec here, I would really understand this. So as an exec member of the board, this would make a lot of sense. As a non-exec director of the board, I think there's more work which either I have to do or we have to do to actually enable it to provide assurance. And I think some of it might be KPIs, but there's also just something about the depth of understanding and what actually is the expectation for NEDs, you know, in this, and what is it that we're saying exec should be holding that understanding. But the bit which I personally feel as though I do need to know and understand is where things are escalating. When there are all of these assurance mechanisms, I don't know whether quality committee is responsible for some bits, or whether it goes to the quality and risk management committee when they're not comfortable with the quality committee. And for me to feel comfortable, therefore assured, that process of escalation and to know where something goes when there is a problem feels like a really important bit. At what point will I know about it? At a subcommittee or at the board when there's a problem? So there's just something about the stairway or the runway or whatever that feels really important as a NED. But I do wonder, and I know it's not done in others, because I had a quick look at some others, about whether there's something important to say who in the board is holding which bits of this, because I'm worried otherwise that I disengage from it rather than lean into it as an edge, because it feels so comprehensive but also quite complex.
And I think a lot of this needs to be done, doesn't it? And the journey's been quite good, and you have some consensus about that, and me too. But we've got to have we've really got to have a detailed understanding of it. But there's work to be done, and whether we do it separately or later, we do it together. We do it with the SRO, and the committee process will give us a way of doing that. got a couple of comments. So Cheryl, and then I think this one.
With you, Simon, you
Yeah.
know, it's a big document to
Yeah.
but I think it's really important that we do a lot of conversation that's going on back with the wider work. So, for example, I looked at workforce things as you would expect me to, and I think there's a conversation about the work, the great work you're doing, that is picking that up in another report. It's not reflected in your in the action plan to mitigate. So the work's going on, but that important part, triangulating the work that you're doing versus the action plan. You know, and I think that can be picked up in something else. It is.
And then we'll finish with Colin.
So I think just building on both, I should just say for new NED colleagues, I'm a Vinyasa, but the reason I'm wearing sunglasses is because of the lights here, which trigger migraines, just in case you're wondering why. Sorry.
We thought it was you wanted to look cool.
Just for the benefit. Yeah. But I guess just picking up on both of those points, I think there is a paper in the private board around reporting, and I think that will help working into the new sort of BAF structure. We're really clear in that these are the core KPIs of the organisation. These are the subcommittees that they will be going into, and I think hopefully that will then make it easier and clearer what each chair, what each SRO within that committee structure is actually looking at, and then clear about what needs to be escalated as well. Because I think that was one of the things as we've tried work through refining the IQPR has been one of the challenges. There was almost too much stuff in there for anyone to really know what am I supposed to be looking for. So hopefully the combination of the new BAF and the new IQPR and subcommittee sort of KPI reporting process will mean that actually we're aligned on both of those things. Everyone's much clearer about these are the things I need to be looking at, and this is what needs to be escalated if it needs to be escalated.
Good. Colin, sounds good.
It sounds really good. I wonder whether outside of here, I do think it would be useful at some point later this year to schedule in one of our kind of board development sessions. It feels like this would be a real opportunity to come back to it. But I think there's something for me about, I think probably as has been talked about, I struggle a little bit with just focusing on the BAF in isolation, because the BAF is a tool within the architecture that we have as a board to ensure we discharge our responsibilities kind of sort of appropriately. So it feels like possibly maybe a conversation outside of here to think about a time point at which we've run it through one cycle with the board, with the subcommittees, but we then have an opportunity in an informal space to come together and start thinking a little bit about, are we really clear about the committees, the committee responsibilities, as has been sort of touched on? Are we clear about how the BAF is, because in theory the BAF should be driving a lot of the activity within the committees themselves. And I always struggle slightly with where you position the BAF on a board agenda, because you put it up front because you want to give it importance, and often boards can be long sessions, but actually there's a real value of having the BAF at the end of the board, because what you would expect is that there shouldn't be anything on the BAF that is a surprise based on the content of the board discussion and conversations that we've had. So it may be that there's outside of here again, we may want to just pick that up as part of the workshop and just think about how does this become a really helpful tool for us to be able to sort of seek assurance in the kind of governance of the organisation in a way that is really kind of sort of effective. But perhaps we could pick that up outside of the chair.
Yeah, absolutely. Well, thank you very much. Moving on to integrated quality and performance reports. So this is under the improve everyday section. That's it.
Thank you, Chair. So good morning, everybody. IQPR is, you will notice, looking slightly different following the previous drafts that we had shared and we've talked through in some of our development work. And I think just before I go into the sort of detail of the report, I guess what I'll say is, reflecting on the conversation we just had, through the work that we had done, we had identified that the IQPR has evolved, I think it was fair to say, from what was previously a very heavily sort of narrative-driven report into then a report that was very much more about metrics, understanding the statistical process charts, variations, but it had possibly grown into too many metrics, and it was becoming difficult to really work out what we should be focusing on. So in launching the new strategy, and with that, the core strategic objectives, we've redone the IQPR so that it does focus on what is it as a board that we have set as our strategic objectives, and what are the key corporate programs that enable those things to be delivered. So that's what we look at. For assurance, the other metrics that we used to monitor through the IQPR haven't gone anywhere, but in effect, they will now be monitored through the committees of the board. And so it'll be those committees of the board, whether it's quality, finance, audit, that will be reviewing some of the other metrics that in effect that are not the standard, not the strategic objectives that we've set. And clearly there'll be a process of escalation up into the board where any of those are off track as well. But hopefully what that leaves us with is a IQPR that is much more focused around what we as a board have set as our strategic objectives. Are we delivering them or not, and where are we against those? Having said that, it's still 50 slides long, so we continue to work on that. So at Q1, against our 12 strategic objectives, one we're achieving, one we're awaiting system agreement in terms of our physical health checks, and the other 10 are either on trajectory or within the statistical process control limits. And some of them at the moment, they're so new that we don't have data going back long enough to tell us where we've got real variation. So we will continue to monitor them, but I'll talk through some of the detail of ones that I think it's important to flag. Of our corporate program, 7 are on track, 2 are amber and 1 is red. And again, I'll pick the red one up a little bit later on. And on our national standards, we currently have 3 which require recovery actions. And again, I'll pick those up in a bit of detail. So in terms of our strategic objectives, I think first couple of things to highlight: agency usage has fallen to 4.9%. And I think it's worth just saying is that is a almost 40% reduction from where we used to be. We were at 7.8% of pay bill. We've got down to 4.9. It's still over the national ceiling, and that's why the work this year around the recovery program is still focused on the agency spend we incur. Vacancy rates are at 11.4% against our internal 10% target. And there's lots of work that we cover off in terms of what we are doing around recruitment incentives and workshops and all the leadership programs in terms of not just recruiting new staff, but retaining new staff. I think the one to highlight in this area is around our sickness levels. We've been talking a lot in terms of our staff survey results and how we make the well-being of them, and I think that our sickness sort of reflects that. It has come down again, I think, over a long-term trend, but still higher than we would want in terms of our internal target. And again, I'll defer to my colleague to go through the details of there. One of the new metrics that we've been looking at through this set of IQPRs is clinical contacts per whole time equivalent. I think on the slide itself, you'll see that it does say it's provisional data, and there is still some iteration to do on it. But I think it is one of the key areas that we have been looking at in terms of productivity. And based on the numbers that we currently have in it, we are under the trajectory we have set ourselves in terms of being at 26 rather than 27 contacts per clinical whole time equivalent. But it is an area of continuing development. And when we launch the new EPR program, when the new EPR system goes live in November, we should have much more robust data to be able to really sort of confirm that we're comparing like for like and that team names are the same, definitions are the same, but we felt it was important that we're recording it early on. In terms of quality and access, I think it's important to highlight in terms of talking therapies, a reliable recovery rate did fall in June, but after gains in April and May. We know that Brighton is where some of that challenge is. That is largely related to workforce, and one of the actions that we've agreed over the last, I don't want to say this, but I think the last 2 or 3 weeks, it was last week in fact, that's how much time has flown, that we will continue with working with the external provider we have been to allow them to continue to do carry out activity in that space for us, so in effect increasing our capacity. I will defer in detail on the 12-hour program to Oliver and to John, but I think it is worth highlighting that is the area within our strategic objectives that we are furthest off target, and we always knew it would be incredibly difficult. It was a very aspirational target that we set. It's our absolute commitment to deliver it, but we recognise we're at the base from where we were starting was very low, and there is a significant amount of work happening around it, but I'll let colleagues talk about those. In terms of a couple of corporate programs that I think is just really important to highlight. The EPR program is currently flagged as amber, and there is a significant amount of activity happening in that space. So lots of the technical builds have all been done. Our data migration is happening. I think it's fair to say that clinical engagement has been challenging, as we would expect. People are busy. Everyone is working incredibly hard, dealing with our patients, and so finding time to ensure that we've got the appropriate level of engagement. But it's something that we've been continuing to work at. Oliver's been incredibly helpful in terms of getting our clinicians engaged with that process. And I'm happy to say our testing cycles have commenced on that now. I actually was doing a site visit yesterday. I ran into 3 people who had just finished a testing cycle and were speaking very positively about the new system. So hopefully once that goes live, that will bring us lots of benefits. I think the other one just to flag, and this is the corporate program that is red, is the Coombe Valley Hospital program. And we will talk about that if people will understand why in more detail in the private part of the board. So I won't mention it here. And on finances, just to say at Q1, we were marginally ahead of plan, but in effect break even, and we are delivering both our CIP targets and we are delivering the workforce numbers in line with the national trajectories at Q3. So I'm happy to stop there and take some questions. And as normal, just for new colleagues or auditors, I'm happy to take the questions, but then we'll direct them to various colleagues who cover those particular areas.
Let's hear from Oliver, and then we'll come to Kathy about the ED wave. So just to say, we'll need to also focus on the stuff that's going well, because there's a lot we need to work on and improve. But the agency rates, sickness slightly down, we need to keep a really close eye on that. I think the electronic patient record, so there's so many opportunities with that. So all the work that you're doing, thank you for that, because particularly the clinical engagement, that'll pay dividends so much down the road. And finally, financial situation for Q1, impressive. Thank you very much, Oliver.
So just to be clear, really what we're talking about is the amount of time that someone waits in any department to get a decision to we've made this. There has been a lot of progress in terms of creating. I've seen almost a halving of section 106 and we're seeing increasingly people and are staying well served, which is actually it's largely led by Southdown, but with our input into this partnership approach. What we've also seen a reduction in the length of stay for working age adults, and also quite a very significant reduction in discharges, particularly in West Sussex. Where we're having particular problems is in a couple of sites, in particular Brighton, which is the footfall there of patients presenting crisis is very significant, somewhat unusual in the number of patients that are presenting there. We have reduced the outliers, so the most extreme waits have come down. The number of individuals waiting has also come down, but the average still remains persistent. It's currently around 4.5 days across the system. That includes community patients. Part of our challenge as leaders is that there are so many actions and activities going on. It's how do you create a coherent narrative that not only allows people to understand what we're asking them to do, but also actually allows decent scrutiny of those plans and also effective communication to our commissioners in order for them to understand the system problems. Effectively, what we've done recently though is to bring in some additional support and capability in order to help us present things in a coherent. Broadly speaking, there are 2 areas of work which, the way I think of it at least, there are 2 areas. One area where we are focusing on the things that really matter, the clinical behaviours that our individual clinicians and the processes that guide decision making and support best practice, and having a consistent model which is aligned with that standards. So an example of that is ensuring that for every single person that's admitted, a consultant psychiatrist has been involved in decision making and shaping plans. So when the person arrives on the board, have exhausted all the alternatives, and we have ensure there's continuity of care, and we have an initial plan for that team to follow up on. So that will reduce the number of minutes and also reduce, as well as improving safety, particularly in the first part of the admission, which is the most dangerous bit. That's quite difficult to quantify the impact of that. But in my clinical bones, I know that it's absolutely vital in order to change the performance. And there are other things though which are much more easily quantifiable with beds today, and having additional beds, and we have models how many beds we need, and certainly in the short term. Effectively, what we're doing, we're looking at can we business case for beds to manage this period of time, what's leadership processes and the different care services which will that's what the capability is trying to do, is trying to help us articulate our plans in a very coherent fashion. At the same time, whilst we're going on with our CQI, thinking about creating a huddle systems where we've got local colleagues working on problem solving and doing rapid change cycles. But I'm going to stop there. I can go on for a very long time.
That's really helpful. But we're going to go to Kathy shortly. And you were saying about trying to discuss clinical models. That's a good example. We need to hear a little bit about it and understand it. Really well done, Oliver. Thank you for that. Actually, before I take Kathy and Anna, and then we're going to have to restrict it to that. I think of time, we may have to defer the break. Let's see how we go. But I want to bring John in because from the operational point.
Thanks. So just to pick up the baton from Oliver, really. So just for quite clarity, so you mentioned South Downs in terms of delivering our staying well services. So they're equally run by Way Through and Sussex Mind. So there's a variety of community and voluntary sector organisations. The other, whilst there is a significant focus on people waiting in emergency departments, Oliver did mention community, but I think it's really important for us to remember the papers that we brought through board, particularly in terms of our response to Calicain. So in our clinical prioritisation of patients waiting for admission, we need to apply appropriate clinical weight to those waiting in the community. This is not just about patients waiting in emergency departments. And the other area that we're really looking at is around length of stay. So you talked about all the processes around admission. Usman mentioned length of stay in terms of where we are a national outlier. So we have been successful, and you've heard me talk about this before a lot, in terms of our reduction in patients who are clinically ready for discharge. And that's really positive, and we won't rehearse all the areas and housing programmes and the work with local authorities. It's not where we want it to be, but we have made improvement, and that's great, particularly in West Sussex. So our focus at the moment now is around the clinical decision making for patients with extended length of stay who are not clinically ready, who are currently still in treatment, understanding what the treatment is, what it's achieving for those patients, what goals are we seeking to meet for those patients, and can we provide them with alternatives out of hospital. So I think Oliver and I are trying to go at this at both ends. I think it's important to present that rounded picture. And of course, as Oliver has said, happy to take any questions on the detail.
We'll take Kathy and Anna then.
So I suppose I just really like the new format of the report. They're really, really helpful in the way you divide it into the sections that you have. I did find it a bit difficult getting my head around the sort of columns with the little coloured blobs. I mean, for instance, the CAMS is green because we presumably delivered those are contacts. But on the variation, it's got a red H, and I thought that would be a blue H. It's a positive variant, but it's just a detail. I'm just trying to understand it, and I found it a bit confusing. But I just want to go back. It was really good to see the corporate projects and the transformation programs getting into the sort of dialogue that we want to have. But again, it's like, how do we get that coherent picture? On UEC transformation, one of my questions is, how does this fit with the 10-year plan and the notion of having mental health emergency departments? Are we doing this instead? Will we be asked to do that? So some questions about what is the overall model. And then again, on inpatient transformation, we've got a multiple admissions pathway project. Presumably that's people that are compliers. where does that fit with the open dialogue work? So it's really, I'm trying to see how all these programs hang together, get some sense of the coherent whole, really. And I thought this was beginning to get into it so helpful, but it might be a workshop based thing for us to be doing.
What I was thinking that Colin was mentioning about a workshop for the BAP, we should on the clinical models, and unpacking this a bit, because we hold the exec to account. It's easier to do that when we understand all the complexities. A workshop that would be a good idea. Let's take Anna, and then if we can, John.
Thanks, Sean. So I mean, lots in this, and I also wanted to sort of commend everyone for the report and the clarity. I mean, I think it's really come on leaps and bounds. Two very lots of things, but two very quick ones in the interest of time. Firstly, on page 29 on sickness absence, will we get a bit more detail on the learning from those 9 workshops? Because I feel like as a board, it would be really helpful for us to know a bit more about, you know, what's been discussed, what good practice has been shared, what data, what policies, and how that can be shared more widely. Because it's, you know, as we keep saying, this is an issue that we really need to address. Second point on page 30, I do worry about whole time equivalent contacts. I mean, I feel like I've for 20 more, probably 30 years, you know, we just have to be really careful about the apples and pears thing that, you know, I know you're on top of this, but I almost feel like we need a narrative now with these charts to show that we are recognising that if a whole time equivalent is 16 in specialist services and it's 35 in wherever, that there's a very good clinical reason why that's the pattern and that's the expectation. Because it's so easily we could get into just the numbers game about this, and you know, we then add to the pressure on our already you know, pretty diminished workforce. So I think having a narrative that explains why there are these differences and having comparisons with national data in there is really going to be really important going forward. Thanks.
No, I was just going to say I completely agree, and I think that we've been really conscious about contacts per clinical whole time equivalent and not creating unintended consequences and not making it sort of just a try to sort of tick box exercise. Then what we've said, and I think hopefully it's in the detail, is that we're actually working with each of the services to come up with a service specific target, i.e. each team will work out sort of using national benchmarks and national productivity work and peer review to say actually what should the appropriate service level indicator be, as opposed to us trying to make something up generically and apply it to not just a division but to, you know, not just a team but a whole division, for example. So hopefully as this iterates over the course of the year, we'll start to see more detail come here and to the sort of to the committee in effect, because this will flow through the Finance and Investment Committee, and in particular at that level we will see all the sub-team data and how we've come up with those specific targets. But I absolutely accept the point, and we're really careful about not sort of using this as sort of one of those sort of really simple KPIs that sort of then has really terrible unintended consequences.
On the second level. Thank you, Alan. So just wanted to see, particularly for our new NEDs and the history around the sickness absence, the trust has been stagnant at over 5% for a really long time. And last year, we came up with this 12-month program of managing sickness absence, which we signed up with the region at the end of last year. And these workshops were one of those programs that we put in place. Now we know, but it's obviously it's not the only thing that has worked. It's a full spectrum of support plans we put in place, and we are now at the 5th month of a monthly steady decline, which evidences, so statistically there has been a statistical improvement, massively statistical improvement, and we've never had an ongoing month-on-month reduction every month like that before. But to the point around the workshops, yes, we've run 9 We have 9 more. What we would expect, or what you can expect, is that at the end of the workshops, there will be an assessment that'll come through People and Culture Committee, because that's the governance route for us to explore the effectiveness of it. To be effective, then we will then roll it out as a permanent BAU. I just wanted to.
Yeah, thanks very much. That's great. Look, just sort of managing the time here. We've gone over a little bit, so we'll defer the break if that's okay. And if anybody needs to, please just pop out. I want to give a bit of time for the Quality Committee and as well. So let's just keep going. So the Quality Committee report, yeah, Anna, please.
You're on mute, Anna.
Sorry. Take the report as read. You have 4 appendices, and we are asking for your approval of the terms of reference for 25-26 and your approval of the quality plan and priorities. Just to go to Simon's point, no new escalations from Quality Committee, but clearly significant challenges around how best to support the workforce and maintain quality with a ever diminishing resources. So some of the areas I think that are of great concern to the Quality Committee have been covered in separate agenda items at this meeting and elsewhere. Just in terms of highlights, I think I just wanted to again note suspected suicides remain high at 29. Compliance with care planning and risk assessments is below our 95% target, and we continue to kind of try and understand why that's such a persistently difficult target to meet. So I think there's some really good work going on around that. Thirdly, the importance of getting it right for families in our review processes. I'm really pleased to see the progress that we've made on that. I think in terms of the quality plan and priorities, there's more clarity now. I think it's much improved in terms of both clarity of purpose and the integration with our strategic objectives. And I think more and more at Quality Committee, we're talking about how dependent we are for so many improvements on the new EPR rollout to achieve that, to achieve those changes that we now know we need to see. As well as the critical importance of supporting our staff through all these changes and continually hearing from patients through various mechanisms. So we commend the plan to you and we seek your approval, as I've said. I just want to say a particular thanks to Teresa, who isn't here today, for all the incredible work that she's done on the quality plan and priorities, along with other members of her team. And just to note our thanks to her at this meeting on behalf of Quality Committee. Thanks, Chair.
Thank you very much. And we need to approve, as Anna says, approve the terms of reference for the Quality Committee, which is standard to review them every year. Thank you very much. Great, very comprehensive, Anna. Thanks a lot. So that takes us on to eliminating mixed sex accommodation. Report
I'll take this as read. You can see from the detailing here, so there's a requirement for us to publish our compliance every 12 months and to externally report any breaches that meet the external reporting requirements via NHS England. Just to draw a few highlights and then some potential areas that we need to think about moving forward. So there are 172 internal single-sex accommodation breaches. That's an increase from last year. Are in compliance with the guidelines as it stands. However, there's conversations and we may need to bring this back. Realising this is overdue, we need to bring it to the following our CQC inspection, which I know we'll be speaking about later. The Havens is an area that we particularly need to think about in terms of mixed sex accommodation, and it's an area that we probably will need to report in the future. But discussions are ongoing regarding that. Lots of work around sexual safety, and colleagues will see our reporting there around sexual safety. The sexual safety group continues to meet, and work is progressing in that area. And you will see a number of areas there in terms of themes and some of the higher reporting areas, which are in CAMS, which is often a higher reporting area. The sexual safety group continues to meet, and work is progressing, and we're looking at the sexual safety charter in terms of where we're sitting in terms of the strategic work around that. Nothing else that I particularly need to bring your attention to at this time, other than to say I will need to bring it back prior to the next 12-month statement being due.
And when, David, will we receive the review on the Haven arrangements we have?
So I think I can bring this back to October.
Mental Health Act Committee. This is Cheryl, this is your first meeting, and you kind of really keen to be the chair of the for your willingness.
There's obviously some kind of story that you all know about.
So it's the first time I've had a formal subcommittee of the board. It should be acknowledged, and really pleased. We've got to get all the legislation right about Mental Health Act. Plus the fact we have, I don't know how many years, 20 or so Mental Health Act managers who work for us on a voluntary basis to review cases, and they're very important. And I'm really pleased that there's an oversight on the board, and you chair the lounge committee, so Cheryl and Oliver just report back.
Yeah, okay, so okay, fine. So first things first, would you like to include terms of reference were very useful for us, as it was our first sub-board committee. I think we did spend quite a lot of time, getting to know and really understanding the data rather than checking and changing as you might expect us to do in the subcommittee. And I think what we've done is asked for quite a lot of data to come to the next subcommittee meeting. We really need to understand the data that's available to us and the story that it tells. And can I just say that Rebecca and I seem to really helpful in terms of being a new chair and so on and so forth. So I just want to acknowledge their particular contribution. They took us through a number of audits that they've done, and we were really interested in the learning that's taking place after those audits, and particularly because of the style of education and learning that's taking place, which I think differentiates you in this organisation. It's not formulaic. It's others and best. We have asked for a deep dive into the patient and care-based quality framework. You'll know already, I'm sure, because it looks like it's a long-standing trend, the disproportionate attention in groups. But also, we did see a newer trend, which was in women. And we met on the mental health act. There's a recruitment process we're going at the moment to improve the diversity of that particular group of people. But yes, so we're starting on our journey. I feel that we're really at the beginning here, and what we'll be looking for time is to tell a story with more data, but also things like that. I'm sure I've missed loads.
No, not at all. I don't think I've got anything to add at all, but just to say that it was great to have our first meeting, and like you said, it was really trying to find our feet in terms of how we can report the data. Again, there's an awful lot of data out there, and I think Alison's even quite all sorts of work methods, but I was happy with that.
Disproportionate rate on cases across the country. What's your thought about when we might be in a position to have a specific plan on that. Yeah.
Yeah.
And the other representation.
Yeah, I mean, I think that largely is less held within the mental health. I think there are effectively 3 strands to that plan, and they are. It's again, we're on a journey to quote Jane earlier. We're on a kind of. I think we need to understand data not entirely clear. So the big breakfast approach is around pulling the goods, but the latter stages of nailing that down, and it's also about getting the data systems so that is continuing BPR as well. We will be boarding, but I think it's difficult to give it a distance now.
Yeah, just one very quick, great report, and thank you very much. And I think one of the areas that we'll probably need to have a think about moving forward around the data is the 136, when patients are decommissioned, because I think that was something that was picked up by our inspection.
Right.
Okay, yeah, they sent some clear messages that they like to see that data from us. So but I'm hoping this new system will help.
Let's have our well-deserved 10-minute break. The annual report. Heads on the charity. Yeah, credit to Rachel Duke, the director. She's very, very good indeed. And Colin, you give a good oversight to the charity. The finances are in good order, although Usman wasn't there to tell me otherwise, but none of your staff told me, and I believe this. The finances are in good order, and you know there's funds coming in. We're impressed with the decision-making process to where they go, where they get delivered. I think there's more evidence that we're putting money into, although it's independent of the organisation to a degree, but we need to help the organisations in our objectives and strategy going forward, and there's evidence that is taking place. And then there was only one action which I think there's a great heart in this in the life of the Nabiola of the charity, and we sort of want to do a bit more, I think, with raising the profile of it and therefore having perhaps an implication to raise the potential for funds. So we said we'd meet outside just to sort of go through that in a bit more detail and see how we can help as non-executive directors. So still need to set that up. So we'll just make a note of that. Yeah. So if I can just finish.
I mean, Jane and I have communicated about it. I'm patron of South Asian Film Festival, which is being this year for the first time. They normally have it in May, whole month of May, showing South Asian films from India, Pakistan, Sri Lanka, Bangladesh, Nepal. This year, for the first time, I've persuaded them to do a film festival over the World Mental Health Day. So kind of 4 days, 5 films, followed by discussions and panel and interviews with actors and directors, and they're going to be doing something similar on LGBTQ plus in February next year. So I mean, if there is a way you think that the charity could be involved in either, you know, financial sponsorship, which is really, really, really small, or in some other way, so it kind of lifts up the profile.
Yeah. Okay. Yeah, we'll look at that. Colin.
Yeah, just 3 very quick things. Thanks, Chair. So just since the report, I don't think it's included in here, just to say that through the charity, we got the Bexhill League of Friends grant for Coombe Valley Hospital. So we got over £100,000 worth of support from the League of Friends as part of that, which I think was a brilliant achievement. We will talk about it more in subsequent boards, but the charity committee has been involved in a Living Histories oral history project, which has been an incredibly powerful piece of work. We will look to be taking this live shortly in the new year. So I think Dan and I were just working through the dates of this, and we're thinking that this will kind of become an exhibition from January. But we'll keep the board updated in the run up to that around some of the stories. I think we've got over 35 different testimonials and stories from staff, people who've used services, right back to the asylum days, up to more recent experiences. So I think it's a really powerful and humbling resource that we are uniquely able to kind of to have. And then the third thing, I couldn't get away with not doing a plug, because I know that Rachel will watch this at some point. There is always a series of ongoing events for charity events for Heads On. Some of them have been quite exhilarating. We have had non-execs running half marathons and marathons. We've also had exec directors throwing themselves off of the I6 365. For those wanting something more sedentary, then there is an open air cinema at Glyme Place later on this year. But I do really encourage everyone, please, at some point through the course of the year, just show some level of kind of sort of support for it. And we're really lucky that we're able to use Glyme Place for lots and lots of events.
Yes, that's true.
Worth noting that.
Yeah. Yeah, no, well, let's think about that, and we get so much paperwork, don't we? Where can we get, should we send out a separate note just for what's going on?
Could do that.
We can. Abiola, please.
Hi, Dinesh, that's great about you being the president of that festival. I think that's amazing. I think we would really, I obviously can't speak for this, CEO of the charity, but I think that it'll be a really great opportunity for us to get involved in that. And then also, if there's any other help that you need regarding that festival and mental health support, there's some work that I do outside of SPF team that works with people from South Asian communities and mental health issues. And so in terms of maybe bringing people to that forum or doing something with SPF team around what we're doing with mental health and people from the South Asian community, I think it'd be worth us offline talking with Rachel about maybe something that we could do that will also at the same time raise the profile for Heads On.
Very good, lovely, yeah, thank you, Abiola. And it's great news about the League of Friends, and the League of Friends are they're great friends in all of the hospitals. But that is one of the things I think we should discuss offline about how we can get support more. I mean, we either have or we're waiting for confirmation, but of course we'd like to the League of Friends that have given us the money in Valley, and I'm very happy to go along to meetings to offer our support. Very good, thanks very much. Okay. The Finance and Investment Committee report for the board to receive the chairs and also to approve the terms of reference for the committee, which you looked at. Anil, thank you very much.
Hello everyone, my apologies I can't be there today. We last met at the end of July. There are no matters to escalate to board, but as Chair said, I invite you to please consider and approve the updated terms of reference. I don't propose to repeat the contents of the note, but would ask colleagues to read that alongside month 3 report and the slide deck that you can find at agenda 13.1. If I could draw 3 areas of the committee's discussion to your attention. 1, headline financial position. 2, digital transformation of the Trust's HR services. And 3, the meeting that we had with 2 representatives of Kia in respect of the delayed construction of Coombe Valley Hospital. Headline financial position first. Although we reported a year-to-date deficit of 3.3 million, that includes a run rate deficit per month of 0.5 million. That is as forecast and to plan. SIP delivery is again to plan, and despite continued operational challenges, I think the teams should be recognised and commended for delivering a year-to-date savings of just shy of 7 million, 6.94, and that being 2.39 million in the month of June. As a cautionary note, I think it's important to say that the profile of our SIP plan means a preponderance of savings is back-ended towards Q3 and Q4. Year to date, although income is under plan slightly by 0.6 million, pay was 1.8 million under plan, largely due to vacancies, whilst non-pay was over plan by 1.1 million, and agency spend continues to be below the NHS cap at 0.64 million year to date. Cash, our closing balance at the end of June was 82.9 million. Unencumbered cash, i.e. excluding capital programme and provider collaborative monies, was 22 million. And forecast year-end cash balance is again at plan at 62.1 million. So the cash position currently is as forecast. If I can take you to our consideration of the digital transformation of the Trust's HR services. As an aside, Chair, I think the committee agreed that the business case presented by Funmi's team was as detailed, thorough and persuasive a case that we've seen in some long time, and that I'd invite colleagues at this board to consider that business case and, in the vernacular, get behind it over time. The aim of that solution, HR solution, is to implement and integrate our HR infrastructure to improve employee experience, productivity, and also service efficiency through addressing challenges such as fragmented systems that we currently have, limited self-service options, and indeed inefficient processes that pose an adverse impact on patient care and employee satisfaction currently. Although the project's financial ask is an upfront investment of 1.46 million over 2 years, and annual license fees of 250,000, projected benefits are a saving of 6.36 million over 5 years and a release of 1.8 million hours in terms of capacity and productivity across the trust, including, importantly, in clinical and frontline staff. The third area to draw your attention to, briefly, I know others will be touching upon this, was our meeting with 2 representatives from Kier, our construction partner. I think it's fair to say, but at the same time important for the board to note, that there's significant overspend and delays to the completion, currently up to 18 months. So it's unlikely that we're going to get handover before, I expect, the autumn of next year. Despite that reality, serious delays, Kier were unable to offer us at committee clear explanation of why, or indeed afford us detailed update in terms of the project plan or updated cash flow statement. I know that in the committee, and I'm grateful not least but especially to Usman and Simon for courteously yet robustly pushing back against that reality. And I know that in the background, Usman is doing a lot in terms of ensuring that our legal position is considered if we need to leverage that, should they, outside our current contract, seek to recover additional monies. That's a précis of what we discussed. Usman, if there's anything else you'd like to add, please come in. If not, any questions?
Thanks so much. And yeah, very comprehensive. Yes. Before we go to Usman,
yeah, I just had a question on our run rate. So I know we are 1.8 million under budget for pay and then 1.1 million over for essentially due to beds and camps. And I just wanted to get a sense of, how do we project those 1.1 million to continue over the year? So what do we look up in the next quarter? Are we seeing a similar trend? And on the pay side, if we were to fill up those vacancies, how much are we expecting to drop the agency? What the balance looks like?
So specifically on that, so within the non-paid position, the primary driver of that is independent sector beds, as you said. We anticipate that's now ended. So that was a non-recurrent charge because there was a delay in effect at the opening of Palmyra Ward, which we had planned for, sort of kind of expected it to happen at the end of the year. The bulk of the rest of the non-pay overspend is actually related to the non-pay CIP target. And I will say, because of the way the planning process worked, I'm being careful how I say this, because there were so many changes late in the day, we allocated an element of our sort of stretch CIP target to within the non-pay position. But the reality is the savings for that are coming through the enhanced work we're doing around pay controls. So in effect, the pay underspend is built into our run rate going forward because it's required to in order to balance off against what will be a recurring figure. You can see there in the non-pay CIP target, 7.1 million. That was in effect the additional CIP in total that the organisation we got to as part of the planning round. The pay savings, which flow through as underspends at the moment, are being used to offset that. The reason we're showing them like that is because, in effect, this was all agreed subsequent to our actually submitting our plans within the national templates. And we're working through with the teams with the national team at the moment, whether there is an opportunity for resubmission of templates, but the reality is those two offset each other. So they will continue in terms of run rate. They're building those.
But the non-bed will sort of stop.
But yeah, the independent sector bed cost will stop off. Okay. That will, in fact, did stop off. I can just as a headline for a month before it pay base dropped out.
Just very quickly, just with regard to the issue with Kia, I noticed that they were looking at taking some very specialist advice around how we have deviated from the plan from time to time and kind of put additional things on. And then, but I just wonder what the risk, what you feel the risk is around that, because obviously that's an additional cost and could be that the whole project could come to a grinding halt. So I just wondered about what we think about that.
So if it's okay, what I'll do is I'll briefly touch on it now, but then we'll go into much more detail in the private section of the book. It's okay. But so we have agreed a specific number of compensation events as set out. So the contract we signed with Kia was through the NEC Procure 22 national framework. Within that national framework, there are allowed compensatory events. And at the moment, we've agreed a number of them, circa £2 million. As far as the trust position is concerned, those are the only compensatory events that we would be prepared to accept and have accepted to this date. The delays that we're currently discussing with Kia are very clearly on Kia. They are not related, as our position maintains that. Now, clearly, I do not know yet what Kia's position is because they haven't provided information, but we can tell them.
We're going to return to this conclusion.
Chair, could I just add to that? Lynn, not that there was any implied criticism in your observation, but it's important to say that in terms of the delay, cost overrun is very largely not at the foot or criticism of the trust. There's been no marked or material change in specification, but rather one, weather, and two, a important subcontractor going bust. I think that would be fair to say, Osman.
Okay, thanks very much indeed.
Yeah, and then we'll leave the rest of that discussion, I think, further. No, not yet. No, it's okay. Kathy.
Income was that if you take out provider collaborative and just look at the SPFT only, we seem to have an income shortfall of £1 million. Then that's offset to give us our overall position. But just wonder what was behind that, because I thought if we'd signed all our contracts and
I will just say at this stage, it's largely timing differences. Timing differences. So we were in the process of our core contracts were largely all signed off. There are a range of, I'll describe them as smaller contracts that we're still just waiting clarity on.
Would you expect that?
Yeah.
And Anil, thank you so much for that chair's report. You can see there are a lot going on there, a lot of detail that you've got a good handle on. We'll return to it in other meetings. But we do need to approve the terms of reference, and we have. Thank you very much. The audit committee, July. Nitin.
Thanks, Chair. I'll take the report as read. This is the first meeting I think we've had since the accounts were signed off, so we had a bit more time to talk about other things rather than just our end of year numbers, which is nice. We spent some time on things that we normally don't spend that much time on. We got to spend a lot more time on counter fraud, which is nice, and really delve into it. We had some good discussions with internal audit and the exec team. We have closed out our consultant and specialty job planning topic that had been bubbling along. They made some great progress at up to like 79%, I think. I think you mentioned, Oliver, earlier, we've got lead psychiatrists in place in 15 out of the 17 positions, which is big improvement. 16 out of 17. Okay. I forgot one. We had a really good session on IT governance. This is one of the topics that was highlighted in internal audit. That was an area for us to focus on. There are still some targets in there. Some of the targets are December 26, and we sort of questioned, why is it December 26? It seemed like simple things like multi-factor authentication and stuff. But as I understand it now, it's based on some system changes that are going to happen nationally. So we are kind of dependent on the national change. So when you look at some of those dates and look at December 26, don't be alarmed, because it's not, as I understand it, it's not in our gift to change it. We got to wait for the change nationally to make that happen. What else did we do? Finally, we had two things to approve. We have the terms of reference. One of the major changes that is going to happen is we will have oversight of the information governance and security subcommittee will now come into the audit committee, which is great because we have lots of topics on governance, especially digital governance, data security. Just having a bit more oversight on it would be great from an audit standpoint. Simon is joining us as part of the audit committee, which is great. Sad to be losing Abiola. And finally, standing financial instructions. I'm going to let Usman give you an overview of this and then come back.
So one of the items we're asking the board's approval for is for a change to our SFIs. And the reason for this is over the last year or so, we've been kind of reviewing how many contracts, in effect, are having to flow through up into either executive committee, up into finance and investment committee, and subsequently to board, that are not always necessarily strategic in nature. And the reason for that is, as we have moved into, and the whole NHS is moving into an environment where we sign longer term contracts to get better value, even for example, £200,000 a year contract, but over a 7-year period suddenly becomes a £1.4 million contract. And therefore there was as my exec colleagues will attest to, a significant number of contracts that were arriving at EC, for example, or subsequently coming to the FNI for a range of issues that we wouldn't necessarily consider strategic in nature that would require board oversight. So what we've done is review our SFIs and propose new sets of limits, which I think, to be completely transparent, are a big different change from where we were previously. So under the new arrangements, board would be signing off things over £5 million. The Finance and Investment Committee would be allowed to sign up to £5 million. The Executive Committee will be given greater limits. And the most significant change is the creation of the Contracts Oversight Scrutiny Committee, SFI authority. So that committee already exists. I chair it, and it's attended by sort of lots of subject matter experts, depending on the particular areas we cover off. And we're granting that committee limits to approve up to £1 million. And that largely is to reflect that we have lots of smaller scale contracts that over a multi-year period, the rules require us in effect to approve not just the in-year value, the whole life value of the contract. We did ask, Nitin at Audit Committee asked a really pertinent question around how does this compare to others? And we've done some of our own benchmarking, but actually to provide additional assurance, we asked RSM, our internal auditors, to review our proposed limits. They have provided that information to Nitin as chair of the Audit Committee. And I think what they've highlighted is our proposed limits are probably a bit higher than peers, but that their understanding, and they've set that out in their email, is most organisations are now looking at this because most organisations are in a similar position to us. Most sort of people don't look at their SFIs that regularly. The factor of inflation and longer term contracts means that most orgs are now moving to a position where you're changing the limits. One change that hasn't made it into the paper that we're proposing is to ask the board's approval to approve the SFIs, but with the caveat that the audit committee would still continue to receive a report that it would review all contracts that were over £1 million. So that even if they hadn't come to BIC for approval, for example, the AC would still be having sight of it, and that we would then review the new SFIs in 12 months' time to see whether it's worked appropriately, whether we feel we still have enough control, or actually if we feel too many contracts have been signed that would be considered strategic in nature that haven't arrived at the board, then we would revisit whether those terms of business are appropriate or not.
Thanks, Osman. Great summary. I covered everything. Yeah, so the checks and balances that we wanted to have in place was how do we compare with other trusts? And there are 3 trusts out of 7 that RSM have shown us that we are about there. They're not that far away from us. And one of the checks and balances that Usman was talking about is reviewing this in another year's time, but also in interim, just getting some feedback on how this is going, which will just give us some assurance that everything is moving on smoothly.
I just think from my perspective, I really like this, but the fact that you're going to put something in a year's time to review gives me that assurance because of course the financial position of the organisation. It's about getting the balance, isn't it?
Absolutely. And I've sat in the F&I committee before, and I know, and we want to also distinguish between renewals and new contracts. So renewals, a lot of times there's only one provider. It's not even a question. We're not even making a decision. We're basically saying, assigning it, we'll be spending time in the F&I committee. Have a distinction between renewals and new contract. That will also be great. So
I really support this. There have been so many times in F&I when I've just been like, there isn't, this is a waste of time. Yeah, it's waste of time because I'm writing it and us reading it and talking about it.
I know you love our laundry contract.
With the caveats that with the
Yes, and so that's the standing financial instructions to approve those amendments.
Yes.
But do you want to?
Yeah, just to add on to the annual report, just to say that they were laid at Parliament on the 16th of July. So since the audit committee, they're now published on our website, and we will expect to publish the audit certification at the end of the month. We've had conversations previously for the audit committee about some delays to that.
Yeah. And can we also approve the terms? Okay. Thank you. Thank you. Excellent. That concludes our business. If there are no items, I'm not expecting any items of any other business, but please do shout if necessary. Thank you very much. We'll close the meeting.